So good morning, and thanks for being here on such a beautiful, magnificent day outside. I appreciate your commitment to learning in diabetes. This is our third and final session talk on the series, Empowering Patients Living with Diabetes. I'm a family physician in Southeast Ontario. I have a great interest in diabetes and love participating in medical education in many capacities. I noticed that at medical education events over the years, that clinicians are typically speaking to other clinicians and rarely to patients directly. With a phenomenal team, we decided to put together these talks directed to patients to not only educate, but empower and inspire patients to take on their condition and greatly improve their outcomes. These talks are completely non-promotional, yet funding was raised via honoraria for the speakers and will be forwarded to the nonprofit entity Diabetes Canada, which is committed to altering the lives of patients living with diabetes. I encourage you to interact by typing questions into the question and answer link. Don't be shy, all the questions are anonymous. If you ask it, someone else will benefit from the answer. I will ask these questions to our speakers after each of their talks. This morning, we have an excellent session. The part one will be on monitoring essentially. And monitoring allows us to know where we are and how we can help predict our outcomes. It's critical in diabetes as in many other things in life. And the second part is a recap of diabetes with a top 10 things patients should know to have better outcomes. With that in mind, our first speaker is Ms. Berard. She's a certified diabetes educator with an expertise in diabetes management, education, and clinical research. She has over 30 years experience, primarily as a nurse manager for the Health Sciences Center in Diabetes Research, the Diabetes Research Program. 30 years, I think she must have started when she was 10. So she has assisted with the Canadian Diabetes Guidelines development, helped develop many diabetes programs, and received many awards. I believe she was Certified Diabetes Educator of the Year in Canada once too. She didn't put that down, but I believe that was the case. She's very humble. So with that, please take it away, Lori.
Good morning, and thank you so much for that kind introduction, and welcome everyone. I would imagine the majority of you are in Ontario, and I was just speaking to one of my kids who lives there, and it's going to be a beautiful day. So thank you for taking an hour out of your lives and spending it with us, because I get great joy out of having the opportunity to help people with diabetes learn about their disease. So I have kind of a little bit of an interesting topic. I was asked to talk a bit about self-management education and about monitoring. So I've got the ABCs of glycemic monitoring, but really what do the guidelines tell us? So I've set some objectives for us for the next 20 minutes or so in terms of what I'd like to accomplish. And what I'd like to do is I'd like to be able in the next 20 minutes, sorry, my clicker didn't work there, is I want to help you understand the ABCDESs as a roadmap to manage your diabetes. So we're going to talk a little bit about that. I know Dr. Steele is going to talk a lot more about it, so I'm just going to give you a highlighted version of it. I want to also talk a little bit about the importance of self-management education and support in your diabetes journey. So recognizing that, this is a lifelong chronic disease and what you should expect and need to be able to successfully manage your own diabetes. And then I'm going to touch briefly on the role of glucose monitoring to support diabetes self-management decisions. And I say briefly because I could do a whole hour on helping you understand your glucose monitoring, but everyone has, different needs and are at a different stage in terms of their diabetes. So it isn't a one size fits all. So just a highlight overview. So why do we do what we do in diabetes, and why do we set up for diabetes education and support? And it's because we recognize that we want to help you live the most healthy life possible. And we recognize that there are complications associated with diabetes. And if we can follow a roadmap to better care, that we may be able to prevent these known complications, things like having poor vessel blood flow to your feet, damage to your nerve endings, damage to your kidneys, keeping your eyes healthy. We recognize that there's also now some issues about diabetes and dementia. So we really want to prevent that from happening. Not many people think about the oral care in diabetes and their potential complication with your teeth. We know that we want to prevent heart disease and stroke for people living with diabetes, recognizing as well that there's sexual dysfunction that goes along with diabetes. And a favorite topic of mine is foot ulcers, because we still know that diabetes is associated with the leading cause of non-traumatic lower limb amputations. And something as easy as taking care of your feet and taking a look at your feet, we can do something about. So on the right-hand side of your screen is the ABCDESs of staying healthy with diabetes. And Dr. Steele is going to talk a lot more about this, but it's a roadmap that we've set out for your doctors to follow, but you can also be empowered and follow this as well. So we know that in terms of glucose control, we want your 3-month average A1C to be less than 7. We have a target for your blood pressure to keep you healthy. We have a target for your cholesterol, specifically your bad cholesterol. We know that there are drugs that can help to reduce heart disease and kidney disease, and they are drugs that are used for other things like cholesterol lowering and blood pressure, but they have a benefit in keeping your vessels healthy. Now, here's where I come in. There's a reminder that diabetes is also about living a healthy lifestyle. So E is for exercise and healthy eating. So determining a regular physical activity plan, getting into a healthy eating plan. Self-management. So diabetes is a chronic disease, and you spend all but probably 4 hours every year on your own managing your diabetes. That other 4 hours, if you're fortunate, you're having conversations with your healthcare provider or your diabetes educator or your pharmacist, and you're getting a little bit of help about your diabetes, but otherwise you're on your own. So you really need to have an understanding, and you need to feel supported. So self-management is about setting goals and identifying barriers that will prevent you from reaching your goals. We know that we have a very comprehensive screening program about what you should do to monitor for complications of your diabetes, that you and your provider should make sure that you're screened for heart disease, that your feet are checked, that your kidneys and your eyes are checked. And if I could ask you to do one thing, if you are a smoker, stop smoking. That is the best thing that you could do for your diabetes. Now, that's a lot of information in terms of that little algorithm. And if you're looking for a really good resource, Diabetes Canada at www.guidelines.diabetes.ca has a whole bunch of patient resources. But this one in particular is my absolute favorite, Staying Healthy with Diabetes. In these 4 pages, there's so much information to help you understand why each of the things that I just talked about are important, and help you identify, why you may have complications, what you could think about, why you might feel a certain way, and recognizing that there are symptoms of these different complications that you might identify and be able to have a conversation with your healthcare provider about, and helping you understand all of the things that can happen with diabetes. So thinking about things like reaching and maintaining a healthy body weight. I mentioned foot care already. We also know that people with diabetes have a higher incidence of both depression and anxiety. So it's okay to not feel okay. It's part of having diabetes for some people, but you should have an opportunity to have a conversation about that. And then, of course, we're going to hear a little bit more about the medical aspect from Dr. Steele. So these are the first couple pages. And then on the 3rd page, it reminds you of the different tests that you should be having on what frequency you should be having them. So, at diagnosis with type 2 diabetes, the screening that should be done, when you should have your A1C done, what should be done every year, what might be done every 1 to 2 years, and then other things that should be thought about. And then your goals are on the last page, and what the target is and what your goal is. So why do I say this? So diabetes is a complicated disease, and it's really important that you feel empowered to make sure that you're getting the absolute best healthcare possible. And so if you understand what you need and why you need it, you can advocate or ask on your own to say, hey, I went to a lecture and someone told me that my A1C should be less than 7. For most people, is that my goal? Or about your blood pressure, and making sure that you're achieving the goals that are set for you. So this is just an opportunity for you to become more informed. And another really nice tool that Diabetes Canada has for you, should you choose to download it and use it, is a tracking sheet. So again, it's your diabetes vital signs, where you are, and any advice or comments that you may need from your healthcare professional. So all of the things I've talked about are listed, and then you can have little notes about it. And why we do something like this is because it's really important that, diabetes is managed by a bunch of different healthcare professionals. And so if we help you be in charge of your own diabetes, you can make sure that you're sharing your information with some of your other healthcare providers. So when you see your eye doctor, or you happen to see your, maybe you see a specialist like a cardiologist or a nephrologist, and just to make sure that everybody's always on the same page, you can be in charge of that yourself as well. So I really am here to talk to you a little bit more about what I call the softer side of diabetes, but I think the most important part of diabetes is that as a chronic disease, you need to have self-management education and support. So education is about helping you understand, and support is helping you achieve your goals. Diabetes Canada has a whole chapter in the clinical practice guidelines that is a roadmap for healthcare professionals to be able to understand what should be provided to people living with diabetes, how to provide it, and then how to provide ongoing support. So I'm going to just give you a few highlights about what I think you should understand in this area. So self-management education is about actively involving you, the patient. And I've talked a lot about this already. We want you to have self-monitoring capacity so that you're involved in making sure that you're monitoring your own health. There's a lot of things to manage in diabetes, and that you're understanding what and how and when. And that also, I always say, my job is to help you understand your diabetes. You can make whatever decisions you want about your healthcare. You can use that knowledge and skills to whatever suits you best. As long as you're informed and you're making these decisions, it's up to you how you're going to do what you do to manage your diabetes. So it's active participation, that you're learning about your diabetes and then you're making decisions. And why is all of this really important is that we understand that knowledge is power. And when we help individuals living with diabetes understand what affects their glucose control, how they can keep themselves healthy, what kind of monitoring they should do, we know that there's evidence that education will improve your A1C or your 3-month blood sugar average, that you have a better quality of life when you understand and can take charge of your diabetes, that there's an increased weight loss that's associated with diabetes education. And we've demonstrated over the last 10 years for sure that we can help people have better overall cardiovascular fitness. So helping people understand the ABCs of diabetes, the glucose control, the blood pressure, and the cholesterol has led to having better outcomes in terms of heart disease. And that's been amazing. When I first started in diabetes, we used to say that 80% of people with diabetes would die of a heart attack. And now we know that about 40% of heart attacks are associated for people living with diabetes. So we've done a really great job in changing that. And that's been amazing because it improves your quality and quantity of life. So what are some of the basic knowledge and skills? So remember I said there's certain things that you should be taught, and that is how you would apply them to managing your diabetes. So it's important that you understand monitoring your different health parameters, as I mentioned, including glucose monitoring. It's important that you understand what healthy eating is. It's important that you understand what physical activity is and the benefits. Diabetes can include a lot of medications, so important that you understand what your different medications are for and how you might adjust them on your own. We know that there are highs and low glucoses that are associated with living with diabetes. So what causes low glucose, how to prevent them, how to manage them. What causes high glucose, how to prevent them, how to manage them. And then, of course, prevention and surveillance of complications. So screening, as I mentioned early. And then you live with diabetes for 364 days and 20 hours by yourself all the time. So it's important that you feel that you have the knowledge to be able to identify problems and do some solutions on your own. So these are things that, as a diabetes educator, I would be really hoping that in our time together that we would cover all of this. Once we have talked about the things that are important for you to know and have as a skill, we want you to then work together. So diabetes education now is collaborative, it's interactive. Back in the day, it used to be that you went to a diabetes center for 5 days and they taught you everything that you needed to know and sent you on the way. But we don't do that anymore. We want to work with you. We want you to be at the center. We want to individualize your education for you. As I mentioned, there are certain things that it's important for us to know that you understand in terms of knowledge and technical skills. But what's more important is that you can figure out what's going on in your own diabetes and change what's happening to improve your glucose control. We know that diabetes is a disease that changes with time, that your life situation changes with time, that what you learn today may not be helpful for what's going on in 6 months from now, so that you are repeatedly being able to understand more, that when you have a question, that it's a needs-based discussion. Hey, this is going on in my diabetes. How come? What could I do to fix it? And that we reinforce all of the positives that you've made in your life. And so we no longer just talk about educating people with diabetes. We want to support them in terms of their journey. And we also want to help you to change your behavior to be able to improve your outcomes, such as glucose control. So how would this happen for you? So in your journey with diabetes, you may have had the opportunity to be with an interprofessional team. So your physician, a nurse, a dietitian, and a pharmacist, perhaps. Or maybe along the way, you've seen a support group run by somebody like Diabetes Canada, where you've gone and you've spent time with like-minded people. That works. An interprofessional team works. Learning from your peers works. We also know that every time that you have a conversation with someone about your diabetes, there's an opportunity for you to learn more. And I always say to my pharmacist friends, a 5-minute conversation with your diabetes patients can make a difference in their lives. We recognize that diabetes is well suited to learn in a group. As Dr. Nerona said right at the very beginning, if you have a question, someone else is going to learn from it. So when we do group sessions for people living with diabetes, often they talk amongst themselves, and we know that's very effective. I would just work as the group leader to make sure everybody stays on the same track and provide expert answers when asked. But also some people do much better in a one-on-one session. And last but not least, especially after this last year, we're really embracing the idea that we spend a lot of time in the virtual world. And so you may have been finding information about your diabetes on the website, and that can be very helpful. So you might be learning on your own and then asking questions. So a combination of self-directed learning and then having conversations. So this is the way that there's no right or wrong answer. It's whatever works best for you, whatever access you have. But certainly, if you have an opportunity to join a peer group, it's a great place to learn from others. And so are our group sessions as well. We also recognize that it's not a one-stop shop, that you should have your education reinforced, that you should have follow-up, that you should have ongoing contact with an educator. And sometimes we use automated reminders, such as text messages or emails, to remind people about things that they need to do, about maybe it's checking your glucose. Okay. So what you should expect in your diabetes journey is that at some point you've had the opportunity to learn about your diabetes, and that as you live with diabetes, that you're also provided support, that you always feel like you know where to turn to, who you can talk to, that someone's asking how you're doing, helping you change your goals, take down the barriers that are in the way for you managing your diabetes. All right. So identify your personal needs, figure out your own options, collaborate, make a plan, and then look for long-term support. And that is the steps to success in self-management of diabetes. These are the basic education and skills. I've given you the official version, but monitoring your health, healthy eating, moving, taking medications, what you're taking, why you're taking them, how you're taking them, high and low blood glucose, what they are, what we can do to prevent them, and how to treat them, preventing complications and coping. So these are the things that you want to know about in terms of managing your own diabetes. In terms of physical activity, we recommend that you get about 150 minutes a week of something that raises your heartbeat, that maybe you feel like you're sweating a little bit and that you raise your heartbeat. And it can just be something as simple as walking 5 days a week, 30 minutes a day, and work towards that goal. Doing some resistance exercise, so doing things, some people like yoga, some people will do chair exercises, doing, using soup cans to just build up some resistance in their, some muscle in their body, so things that build muscles. Setting physical...
Lori, I'm just going to one brief second. For all the participants, if you can mute your volumes, there's a little background noise of someone coughing or something like that. So if you can just all mute your lines, I'd appreciate that. Thank you.
Dr. Naran, I have to apologize. That's my geriatric dog that's coughing.
Oh,
Oh, and that's me, and I really apologize to everybody. He's 16.
I was looking out for you. That's totally fine.
Sorry, my husband just put him outside. Phew. So set physical activity goals and work with your healthcare professionals. Follow a healthy diet. So we don't want to go into a whole lot of, complexities about fats and proteins and carbohydrates. We just know that there are dietary patterns such as the Mediterranean diet, being vegetarian, following the portfolio diet or the DASH diet. But talk to someone about understanding how food affects your glucose control and what changes you can make to your diet. I always say that sometimes people have had things slip into their diet that they didn't recognize were high in glucose. And last but not least, monitor glucose levels. So I mentioned that everyone will have an A1C done. It's your 3-month average. You get it done usually every 3 months, and it should be 7 or less for most people. The second part of that is doing finger stick glucose monitoring. So 4 to 7 before meals, 5 to 10 after meals is our targets. So A1C is one way. So you will have a blood test done, but then you may do self-monitoring of glucose. So many of you are used to the traditional finger stick capillary glucose monitoring, and we're really excited that we now have a different way of monitoring glucose where a filament goes under the skin and measures glucose from the interstitial fluid, and another system where there's a transmitter so it actually pushes the information to a reader. So these are a new way of monitoring glucose. And why that might be something that's helpful is that when you poke your finger, you only see 1 second of 1 minute of 1 hour of 1 day. So here's 6 seconds for that person. But when you have a sensor reading your glucose, it reads every minute. You just have to scan it at least every 8 hours, or it pushes the information to you. But you can see how it fills in the blank and tells us exactly what happened every minute of the day. So this is really valuable information that helps us catch your highs and lows, and it really tells us what it's like for you living with diabetes. And so maybe this is something that would be good for you. So why it's important to manage your glucose is diabetes does not cause complications per se. Uncontrolled diabetes does. So monitoring your health parameters. Other things to think about is good foot care. Are you safe when you drive with diabetes? Do you understand sick care? And remember I said diabetes is hard, so maybe you feel a little distressed or maybe you're having difficulty coping. These are things that you should talk to your healthcare professional about. And there could be many people in your team. And you can see all the different people, your pharmacist, your dietitian, your nurse, your doctor, your kidney doctor, your cardiologist, your eye doctor. It's important you develop an action plan. So when you talk to someone, they're going to help you identify what change you want to make, how you're going to make it. You're going to set goals. You're going to develop a plan. You're going to figure out what resources you need. You're going to recognize how important it is and how confident you are. And that's what we do in diabetes self-management, education, and support. We help you develop a plan. So on my final slide, I just want to remind you that that there's a variety of ways that you can learn about your diabetes. But most important is ask. If you feel like you need more information, ask your healthcare professional. It's important that you access self-management education and support throughout your lifetime with diabetes. It's not one and done. Everything changes with time. And so does our knowledge and understanding. And so does how you live with diabetes. And really having a diabetes team, you have a collaborative relationship, you can set goals, and you can figure out the best way for you to manage your diabetes. And any resources that you might be interested in, guidelines.diabetes.ca, and you can see right here for patient resources, great educational tools. And I'm going to stop there. And again, I apologize for my dog.
Not at all. Thank you so much, Lori. You know, I've worked with you in different capacities. I believe that's actually the first time I heard you talk. You're an incredible speaker. We have some questions that have come through the question and answer link, and some very internet savvy people have directed them to myself too. So there's one question here to start. Can you talk about an example of where a patient follows the best practice and had a great improvement in their A1C? And then the follow-up to that was, what sort of actions do they do to help improve that?
You know, thank you for that very insightful question. I have been working with people living with diabetes since 1987, and there's nothing better than seeing a light bulb go on. So one of the things I think is that diabetes education used to be a knowledge dump, and people just didn't know what to do with it. And I think what's been really important is when individuals learn from each other or from someone, something that might work for them. So a good example is someone who said to me one time, I read a great book. I'm like, oh, really? What book is that? I read a book on the glycemic index. And this person had lost about 20 pounds. And I'd been working with them for 15 years. And the dietitians that work with me were groaning. They're like, we've been talking to him about that for 15 years. And it was when he was ready to make the change. He made the change that was ready, working for him. And I always say to people that you never know when that light bulb's going to go on and something works for somebody. My job is to continue to support you. And the fact that you continue to come to an appointment, even though you haven't made any changes, means that you still are interested in your diabetes. So I believe the best thing is to provide information to people, and they'll figure out what works for them and when they're going to incorporate it. So I have lots of great examples of, I call it light bulbs going on. But again, it's just having conversations, and when something clicks that they want to work on, helping them to work on it.
Thank you. There's a great question on, very technical question for a patient, you know, how does my type 2 diabetes affect congestive heart failure? So what I think we can do with that question is just leave it. And I'm pretty sure Dr. Steele is going to cover that in this talk, but a very good question. Another question here is, can you talk a little bit more about this new monitoring system that you referred to instead of the finger pricks, like the Freestyle Libre?
So there are two, they're called sensor-based technology. So there are two different kinds: flash glucose monitoring, Freestyle Libre. I do this because you flash a reader over the sensor. And then there's a continuous glucose monitoring, Dexcom or Medtronic. And these systems are, I think, game changers for people living with diabetes that are using glucose monitoring to manage their disease. Again, what happens is a sensor reads interstitial glucose, it reads it every minute. And all you need to do is flash to see what you are currently. I could do a whole hour on it, but you can see where you are, where you're going, how you got there, how much time you've spent in your target range, and important information. And that's enough for, you know, every time you scan, you can see that, and you can change your behavior based on that. And then there's lots of great data inside there that you and your healthcare professional can use to make longer term changes.
Fantastic. That's great. Thank you so much, Lori. We're going to move on to Dr. Steele. Our second talk is going to be a wrap-up for this series of 3 on the top 10 things a diabetic should know. I thought, what a wonderful way to end it. And our speaker is Dr. Andrew Steele. He's a nephrologist, which is a kidney doctor, who started his career at St. Mike's Hospital in Toronto. And for the last 20 years plus, he's been at Lakeridge Health in Oshawa. He recently stepped down as the medical director and section chief of nephrology and diabetes at Lakeridge. Dr. Steele served as the executive and regional lead nephrologist for the Ontario Renal Network. He has served on the Canadian Diabetes Association Guidelines Committee, and he's a busy nephrologist and very busy clinical investigator with a vast amount of experience. Dr. Steele.
Thank you very much, and thanks. That was a great talk that I also learned some things from there. I always do, and we're going to fit sort of hand in glove together, I think. So, yeah, I was sort of asked to do a talk to patients, obviously who I'm talking to today, and my job is a very technical one, and obviously I look after patients. But I thought maybe just sort of take it back a step and just sort of think, look, if I was a patient, what are some of the things that maybe I would think of? And I obviously think about things differently as a doctor. But I try to sort of bring it back to sort of how can you take control of this, and it fits very nicely with what you just heard from Laurie. So I think it's excellent. So, diabetes is on the rise in Canada, and depending on how you count the numbers, we get some, data sets say 6 or 7% of adult Canadians have diabetes. Others say 10 or 11. In Ontario and in Winnipeg, actually, or in Manitoba, we've got very good observational data sets where we look at all of the patients who see physicians or hospitals or any point of healthcare, and we look at their diagnostic codes. And looking at things like this, around about 11% of adults in Ontario and probably across Canada have diabetes. And why is this number increasing? Why is it, was it 5 or 6% back in the 90s and now it's 10 or 11%? Well, there's a couple of reasons. First of all, we're probably picking diabetes up a little bit earlier. The definitions of what we now call diabetes is slightly changed, and the sugar values that we and the diagnostic criteria for diabetes. But also, we as a population are growing older, and the older you get, the more prevalence there is of diabetes in elderly people. So that if you're over the age of 70, 75, it's about 20 to 25% of people will actually have abnormal glucose levels or even in fact diabetes. But we're also growing heavier, and unfortunately, 2/3 of Canadians are heavy. Their body mass index or their weight to height ratio is above 27. And that's increasing actually. And we thought for a while it was decreasing, but it's increasing. And insulin resistance occurs more commonly in people that are older, as well as people that are heavier. And fat cells, or adipose cells as they're called, we should just think they were inert cells. They didn't really do much, but they actually do. They make a lot of other hormones, and those hormones block insulin. And when you don't have enough insulin effect, even though you have a lot of insulin levels, but it's not working, you can't sort of burn that sugar and store it away and use it properly. And so those sugar levels increase, and that sort of leads to some of the damage from diabetes. So that's a big issue. And so, at a population level, and that's really not what I'm talking about today, we need to do a better job at educating the population, limiting our portion sizes. I mean, we all eat now on bigger dinner plates than we did. Grandmother had a dinner plate that was 9 inches. When I grew up, it was maybe 10 or 11 inches. Now, often 12 or 14-inch plates in your cupboard. My wife bought plates that were so big I couldn't even close my cupboard. And your wife or me or whoever, I always sort of fill up the plate, and then my kids always want to sort of please their parents and eat everything that's on. And so we eat more calories. We on average eat about 500 more calories a day in the current day than we did back in the 1960s or 1970s. So it's no wonder that we are getting heavier. And although this increase in diabetes, we think of it as a blood sugar disease, as Laurie explained, really it's the complications of diabetes that we worry most about. And most of those complications are blood vessel complications, either the large blood vessels in the bodies or the small blood vessels. And we'll talk a bit about that. And it turns out that if you actually look at the complications of diabetes, you can actually prevent almost all of them, or you can at least delay or maybe prevent completely if we had good screening practices, as well as lifestyle intervention, diet, exercise, etc., and weight loss going along with that, and medical therapy. And then the medical therapy part I'm going to talk a little bit about more today. On the positive side, we've seen a very large decline in the rates of heart attacks and strokes and some of the other vascular events that have occurred within diabetes. But we've also seen a bit of an overtaking or an upsurge in some of the other complications. And one of the questions earlier was about heart failure, and heart failure is one of the things that we now see very commonly in diabetes. In fact, is the most common reason that a person living with diabetes will turn up to the emergency department, not a heart attack, not a stroke. Those things are actually on the decline because we're doing better at controlling blood pressure. We're doing better at controlling cholesterol. We're doing better at, some of the cardiac manifestations, but the heart failure as well as the kidney complications of diabetes haven't really declined that much. So there's still a lot of room for improvement. And so what are some of the things that we can do? Well, as we mentioned, diabetes, although it's a blood sugar disease, it's really a blood vessel disease. And it took, I don't want to say anything negative at all about endocrinologists or diabetes specialists, but really diabetes specialists, until the first set of Canadian guidelines, first set of guidelines in the world ever for diabetes that were evidence-based guidelines that looked at the literature and said, yeah, this is what for sure what we should do because we have this, this, and this trial, was 1998. And those were the first evidence-based diabetes guidelines in the world. But they were very glucose-centric, and they really focused a lot on the blood sugar. And I wrote the kidney chapter of those guidelines back in 1998. But you know, the next set of guidelines, 2003 and then in 2008, moving forward, we started to realize that, look, we're not focusing just on sugar here. We have to focus on the other aspects of people living with diabetes, the blood vessels, the organs, the kidneys, the eyes, the cholesterol, the blood pressure, etc. And so really, when you think about diabetes as a doctor, you know, we'll be screening for damage to the big blood vessels, damage to the small blood vessels. And as a patient, you want to make sure that you do everything in your power to try and protect those blood vessels. And part of that, of course, is controlling your sugar, but part of that is some of the other things that I'm going to talk about today. So 10 things to know to stay safe and healthy in the context of your, and I'm focusing mainly on type 2 diabetes, but this mostly also applies to type 1 diabetes, very similar, just different mechanisms of why the sugars are elevated, but really a lot of the same overlap. So, you know, these are the things that I'm going to talk about briefly. Now, getting screened for diabetes if you're at risk is something that Lori talked about to a degree, or at least the sugar aspect of it, taking control of your blood sugar. We'll talk a bit about that. Following up with your diabetes team, which again, Lori talked a lot about. Healthy eating and exercise, which Lori talked a lot about. Managing your blood pressure. I'm going to focus a little bit more on the medical side, the cholesterol, stopping smoking, making sure you're screened regularly for your complications. Again, that was part of that flow sheet. And then if you have certain conditions or certain factors, make sure you're on the best therapy. This is the part I'm going to focus more on because this is sort of more the medical side, and then back to an overall summary with a bit more medical drill down on those A, B, C, D, E's. So again, getting screened if you're at risk. And again, you know, the first thing is that, you know, when you say, well, there's 6% or 8% or 9% of the population of diabetes, well, how do you really know? Are you really screening? And in fact, people like Larry Leader in St. Mike's have done projects where they've just gone into family doctors' offices and they've screened everybody that came through. Like if you're coming in for a sore knee or you're coming in for a bit of a cough or a cold or whatever, we're just going to screen you anyway. And it turns out like 25 to 30% of people who come to a family doctor's office on any given day have abnormal blood sugar. Now, they may not have frank diabetes, but they might have a high sugar that's borderline diabetes, what we call impaired fasting glucose, or pre-diabetes if they have an A1C that's elevated. So there's a lot of people out there who even have undiagnosed pre-diabetes or undiagnosed diabetes. So how do we know? Well, get screened. And who do we screen? Well, we should be screening everybody over the age of 40 every couple of years. And there's risk calculators that are available. And again, this is something that your family doctor would know. And you can also find that out on Diabetes Canada website. And we screen more frequently, at least every 6 months to every year, if you have other factors, like you have a family history of diabetes, if you yourself are very overweight, if you've got a history of cardiovascular disease, if you're from a certain ethnic population, perhaps indigenous populations, if you have other risk factors. So again, these are things that you and your family doctor should know, and you make sure that we get screened. And how do we screen? Well, it's very simple. We typically do a fasting blood glucose, or we can do, sorry, I'm trying to do the whole thing. Oh no, I didn't do it this way. Okay, let me go back and build it again. So if your fasting blood glucose in the morning is less than 5.6, then that's totally normal. If you have an A1C, and again, what an A1C is, I'm going to talk a bit about in the next slide, but you guys know what an A1C is. That's your sort of red blood cells that are, coated with sugar inside that hemoglobin. Hemoglobin is about a protein that's inside the red blood cells, about 2/3 of the weight of the red blood cell. And red blood cells in your body are broken down about roughly every 100 days or roughly every 3 months. So if you can measure the amount of sugar that's connected to those hemoglobin red blood cells, that gives you an idea of the general 3-month sugar control. So this would be considered normal. If you had either a fasting sugar above 7 or an A1C of above 6.5, then you have frank diabetes. If you have a fasting sugar that's not in the normal range, but not in the frank diabetes range, and your A1C is in that intermediate level, but still below 6, then you're at risk, and we should be screening those people more often. And then if you have sugars that are above 6 to 6.9, not quite diabetes, but not lower, and an A1C in that 6 to 6.5, these are now these pre-diabetes patients. And again, screen more often, but also make sure your patients understand this and say, look, you're at risk of diabetes. And if something doesn't change, you're getting diabetes for sure. So what are you going to do? And what you're going to do is then, let's change your lifestyle. Let's change your diet. Let's change your eating strategies. Let's change your exercise. Let's screen you more frequently. Let's look at other aspects of your health and see, do you have any other illnesses going on? Should we be screening your eyes? Should we be screening your kidneys? Should we make sure we do a thorough cardiovascular assessment, head to toe, etc.? Now, taking control of your blood sugar, again, Laurie's obviously talked a lot about that. Again, this is the A1C story we talked about before, which is this glycated hemoglobin or hemoglobin A1C. We now actually just say A1C. It says the A1C is the easier thing to say. And again, if you look at observational trials, or if you look at clinical trials, and in this case, these are type 1 diabetes, but we've got very similar things for type 2 diabetes, we can see that your risks of eye disease, retinopathy, kidney disease, nephropathy, nerve disease, neuropathy, and then microalbuminuria is protein in the urine in small amounts that are starting to increase as a marker of progression of kidney disease. There's a bit of a rapid uptake in these once your A1C hits above about 8. And if your A1C is less than 7, for the most part, these numbers are beginning to flatten out. In fact, they even continue to go down a little bit, even if your A1C goes a little bit lower, particularly for kidney disease and eye disease. So we have different targets for your A1C, but for most people, we really aim for an A1C of 7 or less, because you can see if your A1C is 7 or less, you're actually having a lot lower risk of these complications than if your A1C is high. In the UK-PDS study, which is one of the largest studies in diabetes published back in the 90s, they showed that every time you bring your A1C down by 1%, so if you went from 9 to 8, or you went from 8 to 7, every time you bring it down by 1%, you reduce your complications of diabetes by 25%. 25%. So if you started at 9 and went down to 7, which is now at target, you've reduced it by 25 plus 25, or 50%. So yes, it's a blood vessel disease, but it's still a very glucocentric disease in many ways, because if we catch people early and we are able to be aggressive with managing blood sugar early, then we can have a big impact on diabetes complications. So again, for most people with diabetes, we still aim for an A1C target of less than 7. However, if you've got fairly new onset diabetes, and you're easy to get your blood sugars down with either diet, lifestyle modifications, exercise, maybe some oral medications, metformin and other medications. If you can do this easily and you've not had diabetes for many years and you don't have a lot of other factors going on, such as hypoglycemia, then why not get down to less than 6.5? And that's what we typically do for those new onset patients. If we can get your A1C less than 6.5, then there's less eye complications and kidney complications. In select people, for example, people that are old, elderly, who are functionally dependent, living in a nursing home, or they've got other illnesses in their life that are, that they're dealing with that are really making it hard to get their blood sugars down, then we have individualized targets. And these are the types of targets that you would meet and you would discuss with your team, whether it's your physician, your diabetes education team, etc. And so individualized targets in some people. So again, we're not always super strict in getting the blood sugar down. And again, we've got to look at the overall sort of patient. And again, we want to try and really focus more now on avoiding hypoglycemia. That's a big part of diabetes management now, more than it ever has been. We've always wanted to avoid hypoglycemia, but now we're even choosing our drugs that we use to use drugs that are safer to try and achieve these goals, rather than just sort of equating all the drugs that we have available as the same. So again, for most people, A1C target of less than 7, and again, that typically means sort of pre and postprandial blood sugars in the ranges as shown here. You guys have known this, and again, it's available on the Diabetes Canada website, and we've heard about again from Laurie. How are we going to get there? Well, again, obviously, it's a combination of lifestyle, changes, diet changes, exercise, weight loss, oral medications, which I'm not going to go into detail about today, although I will have some sections later about medications, and then injectables. And again, injectables in the past used to just be insulin, but in fact now I actually stop more insulin in my patients than I start because I have other drugs like the GLP-1 receptor agonists. So they're drugs that are say liraglutide or semaglutide. These are drugs that are injections that sort of make your body's own endocrine system in the belly work better. which increase your own insulin production and reduce the glucose formation in your body. And these drugs really work well, as do other drugs that help us avoid using or even to help reduce the amount of insulin that people are on, such as the SGLT2 inhibitors, etc. So again, this is for your individual talk with your own physicians, and we'll talk a little bit about certain drugs that might have sort of extra benefit down the road in a few slides. So again, try and keep your blood sugar as well controlled as possible. This will help with delay, complications. And like I said, every 1% reduction is a 25% reduction in complications. That's an important number to remember, because people often say, well, why are you being more aggressive? 7.5 is not that bad. I'm like, well, we can, you're not on that many meds, and I think we can even get better. Let's work together as a team and let's try and figure it out. And so it's important to do that. Again, following up with your team regularly. This is something that Lori talked about a lot. I'm going to not cover that in great detail, other than the fact that the most important member of that team is you and your family. And then all the other people there that you routinely see will be the peripheral people, including me way out on the side as a kidney specialist, but really there's all these other people. And in fact, I'm going to give you an example. In my hospital, I'm at work at what's called Lakeridge Health, which is in the east side of Toronto. And Lakeridge Health has 5 hospitals. Our catchment area is about 800,000 people, 800,000. 11% of adult Ontarians have diabetes. So that means we have 80,000 or 88,000 people with diabetes in my LIN, where I work, right? Only 8,000 people go to the diabetes education program. So there's a large number of people that don't have or haven't taken advantage of all of the resources that are available in the community. And they see their family doctor alone, or maybe they see their, nurse practitioner looking after them. They may or may not have another specialist, but again, there's a lot of people in the community that you can take advantage of. And if I was a patient living with diabetes, I would be like, okay, well, what resources are available? And when you go to the diabetes education program, they'll have access to things like smoking cessation programs and exercise programs and other things. So take advantage of what's available. Lifestyle modification and, diet and the sort of weight loss type part of diabetes is something that every single physician knows is something that should be done, everyone. So they did a survey, but it's a few years ago now, called the Diabetes Strategy Canada Survey, and they surveyed 1,000 physicians, and 95% of physicians said, of course, lifestyle management is important. And that's all of those things, the lifestyle, the weight loss, the diet, the exercise. And they asked those same physicians, is it your job to do this? And 93% said no. Well, wait a minute. If I just told you that most people in Ontario, and I'm not sure what it's like in other parts of Canada, but most people in Ontario are only seeing the family doctor, and lifestyle is so important, but it's not your job to do it, then whose job is it? So again, as a patient, I would say, well, it is everybody's job. And I need to talk to my doctor, and then I need to get into the right team, and I need to have them help me with all of the different aspects of care so that I can meet my goals and look after myself better. So again, you in red here is the most important. And again, how you can help your team is be prepared for your visits. Bring your medications with you. Bring your diabetes logs with you. Bring your glucometer, if it's your, One Touch or whatever you have, or your FreeStyle Libre. Make sure we're validating on a regular basis. Make sure we bring your home blood pressure readings and get your labs done before you go to the clinic. I do that for every one of my patients. A lot of physicians don't do that, and maybe your team doesn't like this, but I like this because I like to be able to tell my people right then how it's going. When you send people for blood work after they come to their clinic, and then you've got to then pull the chart afterwards and then call them back, it just, to me doesn't seem sort of sensible. But anyway, every physician and every team is a bit different. I like to have the labs in advance. Healthy eating and exercise we talked a bit about, and again, I'm not going to talk about this because this is what Lori talked about, and it was part of what I just stressed a second ago. I'm going to move down to the next part. But one thing to remember is that if you have diabetes, and I know there was a bit of a backlash in some people the last time Diabetes Canada guidelines came out, because they started to talk about things like, hooking up with Weight Watchers, etc. And although we don't want to over-focus the weight loss part of diabetes, it's super duper important. In fact, there are some people that are able to come off insulin and come off even all of their oral medications with weight loss. And I've had several patients. I had one patient who was on 500 units of insulin, 500, crazy, like a ridiculous amount of insulin, who was about 450 pounds, who now is less than 200 pounds and is on 0 diabetes medications. And I'm sure lots of you, lots of other physicians, and Lori has got patients like that, I'm sure. Weight loss is definitely not the only part of diabetes management, but it's a big part. and it's a very difficult part to do. But thankfully, there's a lot more drugs in our toolbox, but there's a lot more tools in our toolbox in general that we've ever had before to help people get to where they want to go. But you're not going to get, if somebody says, oh, I need to lose 50 pounds, it's not going to be there in 6 months or even a year. You got to be realistic, set realistic targets and say, look, I'll be happy if I see you in 3 months if you've lost 3 pounds. If you lose a pound a month, I'm happy. If you lose 2 pounds a month, I'm even happier, right? So, you know, it just realistic goals. Okay, managing your blood pressure. Now we're going to get into some of the more medical things. Now, it turns out that blood pressure control is important not just in diabetes. This is a meta-analysis, which is a grouping of all of the studies that have been done in blood pressure control until 2005. There's been some done since then, but there's 27 trials, and in these trials, there's more than 100,000 patients. And if you control blood pressure, on average in these trials, they only brought blood pressure down by 7 millimeters of mercury. So not a lot, but on average by 7. And just by doing that, we reduce strokes by 36%. We reduce mortality by 27%, and we reduce cardiovascular events by 25%. This is in everyone. If we focus in people with diabetes and you aim for a blood pressure of about 130/80, you can have a 50% reduction in cardiovascular and stroke events by controlling blood pressure in people with diabetes. And for that reason, Diabetes Canada has for a long time maintained that the blood pressure target in people with diabetes should be 130/80. If you have high blood pressure and diabetes, then high blood pressure and diabetes together accelerate the risk of complications, particularly the kidney complications, but the vascular complications in diabetes are mainly driven by the blood pressure part of the story. In fact, in that UKPDS study that I showed you before, the reduction of 1% in your A1C that led to a 25% reduction in the complications. In that study, they did a nested sub-study of blood pressure control, and it turned out, and I don't want to say that blood pressure is more important than blood sugar control. It's not. You do both things together, but the blood pressure control part of that study was massively more reduced cardiovascular events than the blood sugar control. So in fact, the blood pressure part was very, very, very clear that we have to be much more aggressive with controlling blood pressure in diabetes than we thought we used to in the past. The other thing is when I see somebody with diabetes who has high blood pressure and I start them on a medication, the thing I have to remember to tell them is like, okay, I'm starting you on this first medication, and it's usually an ACE inhibitor or an ARB, and I'll talk about that in a bit. There's certain types of medications that we should be using as first line for our patients with diabetes because they have extra benefit over and above reducing blood pressure. These drugs also reduce cardiovascular events and, if needed, kidney events in patients with kidney disease. But I say to the patients, look, I'm starting you on maybe 1 or 2 medications at the beginning, depending on how the blood pressure is, but the average person with diabetes needs about 3.5 medications to control their blood pressure. So you're going to need to be on, 3 or maybe 4 medications to get your blood pressure down to target in most people. So it's not a failure. If I see you now and I start 1 medication and I see you in 3 months and your blood pressure is still high and I have to add another, that's not a failure. That's just sort of where we are. So I think we've got to understand that in order to get there, particularly in diabetes, because A, it's more difficult to control blood pressure in diabetes, and B, we have a lower target blood pressure than we do in the general population. In the general population, it's 140/90, but in diabetes, it's 130/80. And for those 2 reasons, you need to be on more medications. So have your blood pressure checked every time you see a doctor, or every time you see a nurse, or anytime you go to a health clinic where somebody's assessing you, check your blood pressure. If you already know what your blood pressures are because you're checking at home, even better. So I ask all of my patients, if they can, to get a blood pressure monitor at home. If you go to Costco or Walmart or one of the larger stores, or even to the Shoppers or your favorite, pharmacy, most places have blood pressure cuffs around about $50 to $60. Sometimes there's very expensive ones, but you don't need to buy expensive ones. If you want one that you know is going to be a good one, look for a little heart with a check mark on it. If it's got a heart with a check mark on it, that blood pressure cuff has been validated by Hypertension Canada. And Hypertension Canada does validate the blood pressure cuffs. Make sure that it's done. And also, it's really important when you're going to the pharmacy to pick this up, ask your pharmacist, is this the right size cuff for me? Because a lot of people have bigger arms or smaller arms. And if you have miscuffing, which your cuff is either too small or too big, then that can make an error of your blood pressure reading by, say, 10 or 15 points. And that's a big difference. So if it's fit properly and you know how to do it properly, and there's lots of videos on how to do this on Hypertension Canada's website, hypertension.ca. If you go on there, you can actually watch videos of how to do it and keep a log. it's actually more accurate than what your doctor or your nurse checks is in the office. Okay, so home readings are very, very vital. And I ask all my patients to get their own blood pressure cuff. And in fact, sometimes I'm even able to help them with that by getting some support through our assistance programs. A word on salt. We all eat too much salt. 95% of Canadians eat too much salt in their diet. If you want to lower your blood pressure, sodium restriction is an important part of this. We should be eating less than 2,000 milligrams of sodium in a day, which is 1 level teaspoon of salt. In order to do so, you have to check labels. If you're eating any canned foods or boxed foods, things that come in those middle aisles of the grocery store rather than the outside aisles, then you're for sure eating too much salt. But I already know you're eating too much salt because I told you 95% of Canadians, they eat too much salt. So even people that tell me they don't eat too much salt, unless they tell me they're checking labels and know that they're eating 1,400 milligrams a day, which nobody does unless they're already seeing us or your dietitians, then for the most part, everybody eats too much salt. So how are we going to eat less salt? Well, the first thing is check labels, okay? And if you have a sort of a stoplight approach, here we have red, too much, orange, watch out, green, go ahead. And then the milligram component is how many milligrams in each of those, packages or cans or whatever we have, which another way to look at it is percent of your daily serving. You want to look for things that are in the green, limit the things that are in the orange, and watch out for the things, or don't even take the things at all that are in red. But the best way to eat, make sure you're eating a low salt diet, is use things that don't have labels on. If you get your own fruits and vegetables and you make your own soup from scratch, then it's got low salt. Whereas if you buy a can of Campbell's tomato soup and you have a bowl of Campbell's tomato soup, one bowl of Campbell's tomato soup is 800 milligrams of sodium. That's like almost half your day's sodium in one little bowl. And if you had a couple of pieces of bread with it, then you're about 1,000 milligrams of sodium. So unless you're checking your salt labels, unless you're cooking from scratch, unless you're avoiding restaurants on a regular basis, we're all eating too much salt. And that's very important for both kidney protection, vascular protection, and blood pressure control. Okay. Only about 10% of the salt in our food is what we add with the salt shaker. About 80% of it comes from processing. Okay. Managing your cholesterol. Again, cholesterol, we always, it's probably the most studied thing in medicine. So it is the most studied thing in medicine. So we know with more certainty than anything else we do in medicine that reducing your cholesterol or adding cholesterol reducing medications in people with high risk reduces cardiovascular events. And we know also with more certainty than with anything else we do in medicine that statins are the safest drugs that you have in your arsenal of anything we do for cardiovascular risk reduction. Safer than aspirin, a baby aspirin, safer than vitamin E, for example, safer than vitamin E. Hard to imagine that. There's a lot of negative propaganda about some of the cholesterol drugs. It's completely negative propaganda. Cholesterol drugs save lives, full stop. And in fact, if you look at these trials, and this is a curve or a graph showing your cholesterol level on the x-axis and the reduction in your cardiovascular events on your y-axis, it's like a linear line. And the trials that have had the lowest cholesterols have had the best outcomes. So now we aim for lower cholesterols than we ever have before. And in fact, we are able to get there because we have more tools in our toolbox. So again, most patients, it's starting with a statin, as these trials did. And statins have shown that if you reduce your cholesterol by 1, so if it was your LDL was 4 and you bring it down to 3, then you can have a 30 to 50% reduction in heart attack, strokes, and vascular death. And if you go from 4 down to 2, which is our target for most people, then that's now a 60 to 80% reduction in cardiovascular events. So we have a very large group of trials that have proven this beyond a shadow of a doubt. So anytime that people quibble about cholesterol, I actually have a lot of slides and handouts that I give to them to read that are very helpful to try and hopefully educate people in the right way. So most people with diabetes are at increased risk for cardiovascular disease, and we can reduce that cardiovascular disease by putting those patients at risk on cholesterol meds, even if your cholesterol is normal. So a large study called the CARD study was a study of diabetes patients, people living with diabetes who had no history of heart disease, who had cholesterols that were pretty good, even normal cholesterols, and they were put on a statin, a atorvastatin, 10 milligrams, and they in fact had to stop the study early because of overwhelming benefit. It no longer became ethical to have a patient like this not on a statin. And there was about a 40% reduction in cardiovascular events and almost a 50% reduction in stroke in that trial. And there's been several other trials that have shown the same thing. So even if your cholesterol is in quotation marks normal, you still need to be on a cholesterol drug because we want to reduce that cholesterol by 50% or get you down to an LDL of less than 2. And we should be checking that regularly, at least yearly for screening, and maybe more regularly if we've got you on therapy. What about smoking? Well, again, you heard Lori said, there's no question. If you are smoking, stop. As a physician, I have to think about the 5 A's. This is from the Canadian Cardiovascular Society. Ask my patients about smoking use, advise them to quit, assess their readiness. When they are ready, when they've gone from pre-contemplation, which is like, yeah, I know I should quit one day, to, okay, I want to quit now. How can you help me? Then I will now assist them with that quitting. I'll make referral and I'll follow up with them afterwards. And there's lots of resources. And if you want resources, smokershelpline.ca is fantastic. But in every single region, no matter where you live, there are excellent smoking cessation resources and tools, more than we've ever had before. Screening we talked a bit about, and Lori talked about. I'm not going to talk about it in great detail. It was in that sheet that she showed you earlier on your patient flow checklist, but make sure you're screened for, at diagnosis. Every 3 months, certain things should be checked. Every year, certain things should be checked. Every 1 to 2 years, certain things should be checked, and then regularly. And again, Lori showed you this before. These tools are available on the Diabetes Canada website. What has become clear is that in people with diabetes, particularly higher risk people with diabetes, certain medications do more than what they're just supposed to do. So ACE inhibitors, which would be drugs like perindopril or ramipril, or angiotensin receptor drugs, which would be like the sartan drugs, valsartan or losartan or irbesartan, those drugs don't just lower their blood pressure, but they also protect the kidneys and they also reduce cardiovascular events. So for most people with diabetes, even if your blood pressure is normal, you should be on an ACE inhibitor or an ARB. And that's fairly clear from several large trials. When we're looking at glucose lowering medications, in previous guidelines, we used to say, well, if your sugars are high, start with lifestyle and then add metformin. And then if they are still above target, here are the drugs in alphabetical order. Choose the one that you think is best. That is no longer the case. We now look for compelling indications. And if people have either an underlying cardiovascular disease, underlying heart failure, underlying kidney disease, or they have multiple risk factors, then 2 classes of drugs jump up as the ones that we should be using. Either SGLT2 inhibitors, which lower your risk of heart attack, stroke, cardiovascular disease, heart failure, or progression of kidney disease, or the GLP-1 receptor agonists, which are the injection drugs like liraglutide, semaglutide. These drugs lower your risk of MACE, or major adverse cardiovascular events, heart attack, stroke, and CV death. Statins, as we talked about under the cholesterol part, and then antiplatelet drugs like aspirin are also indicated in higher risk patients. Not for everybody with diabetes, but if you're older or you had long-standing diabetes, or you already had a cardiovascular event, or you've got other high risk features like kidney disease, then you should be on all of these types of drugs. So it's very important that your doctor thinks about this, because in fact, many doctors in Canada haven't maybe read the most recent guidelines in the 2000 update, which is exactly what I showed you here. For the diabetes drugs, if you have atherosclerotic cardiovascular disease, so heart disease, vascular disease in your neck, previous stroke or mini stroke, circulation problems in your legs, chronic kidney disease, heart failure, or you've got multiple risk factors, then you should be using drugs with what we call grade A level 1 evidence here. In dark blue, you should be either using the GLP-1 receptor agonists, those injections, either daily or weekly, or the SGLT2 inhibitors to reduce those events. So this is really a bit of a complicated table, but I'm just showing you that this is right from Diabetes Canada guidelines. This is something your doctors will understand and your medical team will understand how to read. And you should be asking, well, by the way, doctor, yeah, I'm a high risk patient because remember, I've had this kidney trouble or I've had this heart trouble. Am I on the best drugs to protect my heart and kidney and organs? Because I know there's some changes in the guidelines, and they'll say, oh yeah, you're on this drug. This is the one that your doctor was talking about. This is the one you've heard about. So this is very important. And it really shouldn't be up to the patient to remember this. It should be up to the teams to remember this. And some of this is new, so it takes a little while. So you guys hopefully can be a bit of ahead of the curve here on getting on the right medications. And then putting it all together, and Lori already talked about this, is really just the multi-faceted, multi-professional, multidisciplinary, multi-intervention strategy to reduce these events. And does this work? Does it matter? And I want to just show you two more slides, and then we're going to stop for questions. This is a trial that was published not just once, but 3 times in the New England Journal of Medicine. It's really hard. It's the hardest journal to ever get published in. And this is a trial of people with diabetes who were spilling a little bit of protein in the urine, microalbumin. They only had 160 patients. And they published an 8-year, 15-year, and 21-year follow-up of putting people on intensive therapy, which was, we were going to be a little more aggressive at lowering your blood pressure, a little bit more aggressive at lowering your blood sugar, a little more aggressive at putting you on an ACE inhibitor or an antiplatelet drug like aspirin, versus usual therapy, which is just the way that the patients used to be treated in those clinics. And what they showed was that after 4 years, there was a 50% reduction in kidney and eye complications. After 8 years, there was a 50% reduction in cardiovascular complications. That was, heart attacks, strokes, and amputations. And by 13 years, there was a 50% reduction in death. So just by being a little bit more aggressive in all of the things that I've just talked to you about, even in such a small trial, we have now proof that all of these things matter when we do them more aggressively. So when you have a patient with diabetes, even though we know diabetes is a blood sugar disease, you as a patient and your team should not be or will not be glucocentric, but you need to remember your A, B, C, D, Es, and we'll call these the lifesavers. And that again is what Lori showed you before, is the A for A1C, blood glucose, A1C of less than 7, B for blood pressure, C for cholesterol, mainly a statin, aim for an LDL less than 2. If your LDL is already less than 2 at the start, it doesn't matter. You should still be on a statin, because we know that even in people with normal cholesterol, they still have a benefit by being on a statin. The D for the drugs to protect your heart and your kidneys are the ACE inhibitors, the statins, and then these now SGLT2 and GLP-1 receptor agonists, which we now have several trials for. In the last few years, we've really had a plethora of cardiovascular and kidney and heart protecting trials with these agents, and it really has changed the way we manage people with diabetes. And again, the E for the exercise and eating, and the S for the smoking, screening for complications, and stress reduction. So that was my final slide, along with a reminder to go to Diabetes Canada's website. There are so many tools there. It's unbelievable how much they've done here. There's a lot of tools on your handheld devices. There's tools for physicians and diabetes professionals to help decide which drugs these patients should be on, how we can manage. It's just they've done a great job with knowledge translation and support for people living with diabetes. And really, kudos to Diabetes Canada and everybody who's been involved. So I think that's me done there. We're happy to answer some questions.
Thanks so much, Dr. Steele. We appreciate your passion and commitment. We're going to go through a few questions. I apologize, we're a little bit over time, but I couldn't stop such great talk. First question, does type 2 diabetes affect congestive heart failure? Is there something we can do about it?
Right, so heart failure we typically talk now about heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. That means reduced ejection fraction means you've had some damage to your heart. So most people with heart failure who've got reduced ejection fraction have already had a heart attack, either the one that they knew about or one they maybe didn't know about. And the treatment then is to treat the cardiovascular disease, make sure that we have a cardiologist involved and see if maybe you need some revascularization, go on all the right therapies, statins and antiplatelet drugs and drugs to control your blood pressure, ACE inhibitors, all the things that the cardiologist would want to use. But the heart failure with preserved ejection fraction is a sort of a more interesting group. And those are people that might have a good heart pumping well, but it's a little stiff, it's not working, it's not relaxing as well. And people with diabetes have a lot of heart failure with preserved ejection fraction. It turns out that in people with diabetes, there's a lot of undiagnosed heart failure. And if you look at the diabetes trials with a class of drugs called SGLT2 inhibitors, we actually had a very large reduction in heart failure hospitalizations, heart failure diagnoses, or heart failure admissions to the hospital, and complications and death from heart failure when we use SGLT2 inhibitors. So that was unexpected. We were doing these trials to say, are these drugs safe? Are they safe in general for heart attacks and other vascular? And we saw this amazing reduction in heart failure. So the people that in the know were smart and said, well, let's design heart failure trials. And we've now had 2 published heart failure trials that show that SGLT2 inhibitors in people with a diagnosis of heart failure who've got this reduced ejection fraction, it makes you live longer and have less cardiovascular events. So the heart failure story within diabetes is this. It's very common. It's becoming one of the leading causes for admissions to the hospital. and we have new tools in our toolbox, these SGLT2 inhibitors, along with the other classes of drugs that we use for heart failure, the what we call ACE inhibitors and ARB drugs, the beta blocker drugs, and then drugs called mineralocorticoid receptor agonists. We now have 4 pillars of heart failure protection in Canada and throughout the world. And one of those pillars is a diabetes drug, the SGLT2 inhibitor. So diabetes and heart failure intertwine, and so much so that one of the pillars for managing heart failure, even in people without diabetes, is this diabetes drug called the SGLT2 inhibitor. So again, if you have heart failure or you're at risk for heart failure, make sure your doctors are screening and you're on appropriate therapy.
Great, thank you. Does metformin help older men with enlarged prostates?
Not necessarily, I don't think. Not that I know of.
Not
does it?
I either. Not
No,
that I, but it's a good.
Yeah, if you have an enlarged prostate, then typically, I mean, in the olden days, urologists would be lined up like 50 patients. They'd be just scoring out one after the other of a prostate called a TURP. Now we don't do that anymore. We've got great drugs that can, block the androgen effects and alpha blockers. And so medically, we can treat your prostate very well with medications. But I don't know, is this something that I just don't know about, Lori?
The only thing I would say is that there could be a association between less need to have to go to the bathroom at night if your metformin is successfully lowering your glucose. So no, it doesn't help with the actual disease of BPH, but in fact, if you lower glucoses, you may need to urinate less at night. So it might actually help with the symptoms, would be my thought.
Excellent point. Really good question. Why do blood sugar numbers rise and drop dramatically through the night, even though your medications, eating are quite stable, including if you're on insulin?
Yeah, so there's 2 things about that, and the first thing that comes to my mind is that we don't necessarily ever appreciate the effect of activity on our glucose levels. And activity also usually appears not at the time that you're doing it, but you see the benefit of activity or the benefit of lowering glucose of activity later, 4, 5, 6 hours. And it doesn't matter what kind of diabetes you have. So sometimes if you're having difficulty overnight, it's because maybe you've been unusually active, in the evening. And if you're on insulin, you haven't reduced your insulin dose, or you didn't maybe have an extra snack to think about that. But one of my favorite topics around when you don't understand what's happening with your glucose levels is that if you're not using healthy insulin sites, that you could do the same thing 2 days in a row, but if your insulin is going into an area of lipohypertrophy, so fatty tissue, that your insulin may be absorbed differently than if it's in healthy tissue. So sometimes when people are having trouble with this, which we would call variability, one of the first things to do is check where you give your insulin. Are you using healthy sites? If you're using an insulin pump, are you changing your sites regularly? So sometimes it's how the insulin is being delivered. So the 2 things, activity and insulin delivery to me. Maybe, I don't know if Andrew wants to answer that.
Yeah, no, I mean, and that's part of it. And the other thing is, I think everybody thinks that you absorb your glucose like at the same rate every day. And again, people have different levels of absorption, especially with people with gastroparesis or some damage to the nerves in your stomach. And, the food you eat, you don't necessarily absorb all that glucose immediately. Sometimes there's a bit of a delayed absorption. So yeah, I think there's a lot of other factors. And again, it's the overall control rather than any individual variation that we worry about.
Thank you. There's a question, a patient was diagnosed with diabetes in November, their A1Cs are still high. What are the complications they should be worried about? So just for some time, it's been dealt with, but really, I always think top to toe, your brain, your eyes, your heart, your kidneys, your blood vessels, erectile dysfunction, poor control affects all of this over time. Also, there was a question, is A1C different in children?
Sorry.
Yeah, please, Lori.
The only reason I would say, so for that question about high glucoses when diagnosed and A1C high, just make sure you've been screened for everything, because we know that there's often complications at the time of diagnosis. So if it's type 2 diabetes and it's been around for a while, you should have screened for everything that Dr. Steele talked about as well. So that's
absolutely
the thing to do, is make sure you're
in the UK-PDS study, these were new onset diabetes, and 20% of them already had retinopathy, and 20% of them already had protein in their urine. And it takes a while for that to develop, which means that new onset diabetes isn't really new onset diabetes. It's been there for a while beforehand in many patients. And family doctors, unfortunately, don't often like to label patients, or maybe I don't think we ever lie to our patients. We don't do that, but we insulate them from the truth. It's unbelievable how many people come to see me and they're already got maybe stage 3 kidney disease, and they've got a bit of protein in their urine, or a lot of protein in their urine. And I'll say, well, I'm looking back in your charts and I see you've had, diabetic kidney disease now for about the last 3 or 4 years. And they're like, no, it's new. My doctor just told me. So I think we have to be open with our patients and make sure, look, yeah, there's some, you have diabetes. I'm screening for these things. There's a bit of damage to your kidneys, but don't worry, we're going to fix it. And then down the road, if you need to, we'll send you to a kidney doctor. And unfortunately, I think, there's not always good communication both ways. So make sure that you open up to your doctor and ask them these things. You guys are the most important part of the team. So ask the questions if they're not telling you the answers. Make sure that they do.
Thank you.
I'm not trying to say everybody's like that, but there's certainly, like I said, it's important to know, because, you're the one that's in charge.
I appreciate that. And, I'm just trying to be a little bit time sensitive. So if we can just answer these super briefly, is there A1C target different in young children with type 1 diabetes?
So it is less typically in the for children living with diabetes, type 1 diabetes, the clinical practice guidelines states a target of less than 7.5%. So it is different, but it, again, individualized by who's managing you, what you're using, what kind of glucose monitoring you're doing.
Excellent. There's a question here. Considering you follow the medication regime prescribed, is weight loss the best way to reverse diabetes?
Probably. I mean, there's, I don't know if you're going to reverse it, but you mean getting off your medications and getting your numbers under control. And obviously, the earlier you do this in your disease, the better, right? If you start later on, it's going to help control, but you're probably still going to need to take medications. But like I said before, if I've had several patients who've had large weight loss who've been able to come off all of their insulin, off their medication, like many patients actually. And there's some people that do that and believe in this in sort of an unusual way, where they do like crazy intermittent fasting and all these other things. I'm not sure that's the safest way to do it, but it should be part of anybody's strategy for management of diabetes is weight control. And if you are able to lose weight, you will find that you need less diabetes medications.
Thank you. Go ahead.
So all I would say is that we do know that there's lots of work going on in remitting diabetes, and it's doing something that we're not used to, which is, yes, intensive lifestyle intervention, try to lose some weight, get into a lower carbohydrate diet. And then there's these research studies looking at hit them hard, hit them early. So instead of starting 1 diabetes med, they're starting 3, and they're sort of, getting glucoses down and giving your pancreas a chance to reset, and then you can remit it for a while. So weight loss is huge. I would say carbohydrate content is another thing that's really important to look at.
In the new trials that are coming, the GLP-1 receptor agonists, some of the newer ones that are coming, these injectable drugs, with these drugs, almost 50% of the patients in the newer ones have A1Cs that return to the normal level of less than 5.9, which is unbelievable. So we are seeing a change in therapy for diabetes right now, some of these trials haven't even finished yet. So the future for diabetes is very strong and bright, I think.
Excellent. Couple more questions, and I'll wrap up. What are your thoughts on intermittent fasting as a tool to manage diabetes and I guess you could put in their weight?
If you are on an SGLT2 inhibitor, I would caution against prolonged fasting. But I like intermittent fasting in general. I mean, our bodies are meant to have fed states, which means we have metabolisms and physiology built up to store calories and carbohydrates and fats. And then we also have a physiology built up to burn fats and carbohydrates. So that's the fasted state. So we're supposed to be hunters and gatherers by nature. We're not supposed to eat like 800 to 1,000 calories each meal 3 times or 4 times a day. We're supposed to be foraging our food and sort of, getting, eating sort of a Mediterranean type diet or a paleo diet or whatever. And which means there are times when we're supposed to fast. And so I like fasting, but be careful if you're on insulins, be careful if you're on SGLT2, talk to your team and devise a sort of a healthy way to do so. But if you're on oral agents and you're pre-diabetic or diabetic and you want to try and lose weight, anything that works for you works well. I like, whether it's, Atkins diet or Zone diet or South Beach diet or, Health Canada diet or Weight Watchers, whatever works, right? So I don't think you need to spend a lot of money to go see Dr. Burstein or one of these fancy guys. Just do it on your own. But Jason Fung has written a couple of books on intermittent fasting. I mean, he tried to study it. He didn't get funding for it. I like his approach, and I've got a lot of patients do it, but I've also seen a few patients come into the hospital with diabetic ketoacidosis because of this, because they did it in the context of also being on the wrong drug. So make sure you really are set up with your team if you're going to do this. And Lori, I'm sure you have this question all the time.
Yeah, so I like intermittent fasting. There is evidence that it works. My only other addition is that if you're on a glycoside, so a sulfonylurea, that's another, you have to be very careful. So insulin, sulfonylurea, or SGLT2 inhibitor, because you want to avoid issues related to not having enough carbohydrate when those drugs are on board.
Fantastic. Just for time, we're going to have one more question before I ask that. I'd ask all the participants to go to the chat. There's a link for evaluations. It's very valuable for us to get your feedback in developing future events, which Diabetes Canada has expressed an interest in. So please do that while we have the last question and wrap up. So last question would be, the Libre causes me to break out in a rash. Any recommendations?
Yeah. So Andrew, I'll take that one.
Yeah. Thanks, please.
It's a bit of a tough question because you really need to make sure a few things is that you're preparing your skin properly. So it's clean and dry. A lot of people wipe it with alcohol and then stick the sensor on, and so there's wetness underneath, or maybe it's the alcohol that's causing local irritation. Some people have sensitive skin. So there's certain things that you can try to do. One is make sure that you're changing your sites, that you're not going back to the same one, that your site is clean and dry. Dry is huge. And then you can use a preparation like a skin tack or a liquid bandage, and it actually will cover the skin, which will allow you to have a bit of a barrier between you and the sensor. Unfortunately, there seems to be less reporting of it, and I think that that's maybe because there's a little bit of a change in the adhesive, and I don't know that for sure, but I think it's proper skin prep. You can use something that's a bit of a barrier between you and the sensor. Go to your healthcare professional. This is something that they probably have a bunch of tools in their toolbox about. And last but not least, again, make sure you change your sites. Don't go back to the same site over and over again. But it really is individualized, so I don't have a great answer to it. It's really more about skin prep and perhaps a barrier.
Thank you. One thing that I could add, clinically, a lot of these devices require a glue to stick to your skin, and often it's not the device, it's the glue. So with a lot of patches, what I recommend is the patient dries the skin, cleans it, and then your doctor can prescribe an inhaled steroid puffer that we use in asthma, and you puff it on the skin. That reduces the chemical reaction or the contact dermatitis that's occurring.
Yeah.
But fantastic. You've been very patient with time. We appreciate your commitment. Just a few final wrap-up thoughts, and then I'll thank everyone. Lori raised a great point about the personal tracking sheet for your diabetes on Diabetes Canada website. That's a great tool that helps you oversee your condition. She repeatedly said these words, you monitoring your diabetes. So this really resounded for me as a critical thing for a diabetic. Now, diabetes is a team approach. Your family doctor, your endocrinologist, your nephrologist, cardiologist, your diabetes nurse educator, dietitian, pharmacist, personal trainer, your family. These are all your team. If there's one sentence I could leave you with, you are the captain of your condition. You have to be the driver for your care. That really changes things. Both our speakers reinforce that diabetes is a condition that affects a lot more than your blood sugars, all the organ systems we talked about. Dr. Steele went in detail about A1C less than 7, blood pressure less than 130/80, get your cholesterol down, at least under 2, maybe under 1.8 for your bad LDL cholesterol. Statin drugs, despite what you hear on the imminent news sources like CBC and the Toronto Star, save lives, quit smoking. These are some of the take-home things. That last study, the Steno-2 study, is one of my favorites. I had to read it twice. I couldn't believe as a clinician that 160 patients followed over this time could have that vast clinically significant outcomes of about a 50% reduction. So all these boring things that we talk about, blood pressure, cholesterol, A1C, quit smoking, it cumulatively vastly affects your outcomes, not even getting into medications so much yet. That you can get into the SGLT2s, the GLP-1s. This is what transforms your future. This is not esoteric, this is real. So with that in mind, just like to bring it to your awareness, we're doing our efforts to get recordings of all 3 sessions on the Diabetes Canada website. Please do your evaluations. And I'd like to thank the following people. First of all, I have a team of wonderful people who helped me get these going. They're so modest, they did not want to be named, but I know who you are, and thank you very much. Grace Leader in Diabetes Canada, thank you so much for all the technical support in having these. Most importantly, thank you, Ms. Berard, thank you, Dr. Steele. Your passion, your commitment, it comes through in your talking. These are free sessions you did, and you would be here all day answering questions. I appreciate your commitment to our patients. And lastly, you, the participants, I'd like to thank you for attending, your great questions. I hope you learned something today. And more importantly than just being educated, I hope you're motivated and empowered to take on your illness. You can absolutely change your future outcomes. Thank you very much. I hope you enjoyed the rest of the weekend. Have a great day.
Thanks, Lionel. Thanks. Bye.